Okay, so I'm glad to see all my friends here and those other people too who are interested in the Fidelity and competence. So, of course, I'm going to start with the assumption that everybody here is on the EBP bus. Would that be correct? Because this isn't a very relevant topic if you're not. Because really the issues of competence and fidelity are relevant to the delivery of evidence-based practices. We're not really all that interested in people being competent in ineffective interventions. So just to be clear, that what I know about this and the thinking I've done with my friends and colleagues has been really in relation to implementation of evidence-based practices. So mostly what I'm going to talk about, you could have saved yourself coming down here and read about it in our everyday competence and fidelity guide that we developed as part of our CBT Plus project, where we're training public mental health providers in 4 different evidence-based practices that would reach about 75 or 80% of their clients. And of course, the issue of competence and fidelity immediately comes up when, once you get in, we're not just interested in doing a training, we're interested in people doing it in their real life environment and doing it in a way that's going to produce the outcomes or close to the outcomes that you would see in the research studies that decided these were evidence-based. And of course, once we're training, unlike most programs that are training people in a single intervention, just the very idea we're training people in 4 different clinical targets: CBT for anxiety, CBT for depression, trauma-focused CBT, and parent behavior management. You immediately encounter, once you get beyond the one at a time, how does an organization come up with a way to make sure that people are competent and they are doing it? So I'm happy to share this with anybody who's interested. I think it might be on our website, but if not, you email me. So the way we define this, and a lot of our thinking came out of meeting with senior leaders in various public mental health centers around Washington, were to address 2 questions that are relevant for organizations. Essentially, we've reduced it to, we're big on simplifying, that competence really means, can they do it? Some of the skills that are part of evidence-based practice are not ones that a lot of people, certainly not the workforce in public mental health, which is mostly master's level providers, social workers, MAs, masters in counseling, and that sort of thing. A lot of these skills that are novel to these providers. They haven't been taught this in their general education. So a training program that just says, here, you should start doing this instead of that, when it's not a skill that people don't even know yet, means that getting people competent in the essential ingredients is a very important part of the training. And the second part is, okay, now people are competent, because we don't really care about fidelity if providers aren't competent. I mean, sticking to a program and not doing the elements of it competently is not really what we're after. And it was interesting, I did have a colleague in my office, Naomi Perry, who's an expert consultant on PCIT, came to me with this exact question about someone that she's providing the consultation for who has been struggling with, and PCIT is a pretty, it's a very highly structured intervention. It has to be done in a certain way. And the struggle she was having is that the provider was now sort of following the plan, sort of being faithful, is what fidelity means, and doing the things that were required, but the way she was doing them were not really likely to produce the result with the families. And then just an obvious example of that, taken away from any specific EBP skill, would be somebody who's trying to do engagement with a client and they're completely cold in the way they present themselves. It doesn't matter what they say, because engagement is more than just saying the certain words. But then we do have the question of, okay, now we got the people competent. They say they know they can do it, but are they really doing it? And that is a very tricky question when you're talking about public mental health, which is where my biggest interest lies on this because that's where most kids get their mental health care. And in public mental health, as I know everybody knows, people have high caseloads. They have maybe 40 plus, and I'm guessing, Maria, in case managers in adult mental health have way more than 40. What would you guess? The
60
number?
to, I had 75 as a case manager.
So 60 to 75 cases that you're supposed to keep track of and follow a plan with. And the problems people have, it's not one, it's the whole gamut. So I've been trying to figure out how many evidence-based practices would you actually have to have in a public mental health setting to provide evidence-based care to everyone who came in the door, which is what their mission is. It's not just treating people with this problem or that problem. And now you're getting into, I would say, the high teens, if not more, if you try to cover it. So thinking about how would an organization keep track of whether their providers are being faithful to a model across 15 to 20 of them. So that is why we stole from our program manager in DBHR, Greg Embler, the words everyday fidelity and competence. So we're really orienting towards what are ways to do this that can actually be incorporated into real world practice. And Greg had attended our senior leader meeting, and as we were chatting about what he was hearing from all these senior leaders in public mental health, he said, we need something that's every day. And I thought that was a really great way of capturing the challenge. So why does competence count? Well, I always love this example because this is an example where from Washington State, it's functional family therapy. This is from a Washington State Institute for Public Policy publication on juvenile justice interventions. And what do you notice there about the difference between the competent and non-competent providers? Now, we're not just talking about somebody staying depressed, are we? We're talking about serious juvenile offenders actually having an increase in their recidivism rates. That means someone else is being directly affected by this because they're the victim of the crimes these kids are committing. And so when competent providers can reduce serious violent recidivism by 38%, and non-competent ones are going to increase recidivism, well, we should really care about it. That's a very dramatic illustration of the importance of competence. Now, fidelity, I mean, one of the complications is the terms, but if we use the term fidelity in this case to be comparable to adherence, meaning sticking to the program, doing the things that you're supposed to do in the program. This is just a graph from a multisystemic therapy study, and they've been very strong on the importance of fidelity. They've published quite a few papers showing that if you don't have fidelity to the model, meaning people aren't sticking to the program, that you don't get the results, and that there's a very big correlation between people sticking to the program and getting the outcomes for which the intervention is designed to arrive at. And in both these cases, they are, the outcome of not lowering recidivism effect is not the same. It's not just somebody staying depressed. It's people in the community suffering further victimization. So there are two basic ways, and I'm sure that I'm oversimplifying a very complex subject because we are very good at making everything very complicated, but so please point it out. Erin or somebody probably knows more than I do about it. But essentially there's two different ways you can measure these things. One is direct and the other is indirect, and everything falls into one of those categories. So the direct methods basically are seeing someone do it. That's what it comes down, or hearing it. So you're not hearing somebody say what they did, you're seeing it, you're listening to it, you're watching them. So as you can see, you can read here that we just made a couple of columns, one for competence and one for fidelity, that you don't have many options. I mean, either you're going to have tapes or you're going to be in the room with people watching what they're doing. Maybe for competence you can use behavioral rehearsal or having people role play a skill as a method of learning. Can they really do this skill? But can people do it in your office might not be quite the same as can they do it with a real world person. When indirect methods essentially are other ways of finding out about it from either providers reporting this is what I did, or I think I'm really competent at this or that, or in the case of some, in terms of fidelity, meaning ongoing, are they sticking with the program? Well, detailed case discussion turns out to be pretty, I mean, for example, in multisystemic therapy, that is one of their main ways of measuring fidelity. They have such high levels of supervision and discussion about what people did that they're able to get a pretty darn good handle about what went on when the providers were delivering the intervention. They also, another thing MST does is to have surveys of families, have them say what happened in the services. Or fidelity can be, indirect methods might be progress notes or charting and that sort of thing. So to think about what's the gold standard for measuring competence and fidelity? So against what are we talking about? When we're talking about every day, it's not really going to be a gold standard. So we're really going to talk about, well, how far off from gold standard are we? Well, in a typical randomized trial, basically, competence and adherence are generally evaluated at the same time and in the same way. So they're kind of subsumed together. But the typical way would be that the people who are going to deliver the intervention are given practice cases, and they are supervised and with feedback. And they're taped, and then they get extensive feedback, and then they practice some more until they demonstrate that they've achieved mastery in delivery of that intervention. So we have a randomized trial going on in our shop for comparing two different approaches for adults with PTSD and substance abuse, and where they're being randomized to get a PTSD treatment first or a relapse prevention first. And they couldn't even begin doing the study until they had done multiple practice cases, all taped with heavy supervision. In terms of fidelity, meaning the adherence to the steps within the program, they tape it and they code it. And the coding can get pretty detailed, given that I was just on a call yesterday with our Shannon Dorsey about coding providers' tapes of sessions. In that case, the intervention is trauma-focused CBT, and it's coding 5-minute intervals. And we had this unbelievably long conversation about, well, what is this little thing? How would we code that? Because of all the things people can actually do in a session and how much time they spend doing that. And literally we had a 15-minute conversation about how we would count a provider going, Now, so and of course, this is a really necessary part of doing a randomized trial, because if you don't know what people are really doing, how can you attribute any results to the intervention or not, or the usual care? You have to do it that way. But as you can imagine, these kinds of methods are pretty far from what is realistic in everyday community mental health settings. It's really a non-starter to have this level of practice and supervision to mastery, and then ongoing monitoring, coding, checking on the various, what they're doing every single session. Now, it is true that in some interventions, like functional family therapy or MST, and I'm guessing Eric in FIT, that it's not so much coding and videotaping what people are doing, but knowing everything about it through the high level of discussion and supervision of everything they're doing. You're talking about small teams with somebody really reviewing every single thing they do. So in our conversation with our colleagues in mental health, as part of producing this product, we went out and took a look at, well, what are some of the ways out there that exist out there to measure competence and to measure fidelity. And what we found out, which was really pretty interesting, and I thought was great news, because what we found is everybody does it differently. I mean, in your randomized trial of an intervention targeting depression or anxiety, that's where you tend to get this coding for every single session and what everybody's doing, but that's not how every intervention is actually monitored in the full array of interventions that are available and out there, which is, in my opinion, the more flexibility and options we have, the better off we're going to be, because there are more chances people can find something. So you can see that it's really kind of varied. These are all of these are, you know, highly regarded interventions. They do different things for different populations, but they all have, with the exception of Triple P, which I find to be so interesting, doesn't even have any kind of fidelity monitor. Now they have a competence evaluation, because I personally had to do 2 role plays and get judged by our very own Dr. Sue Kearns, and I had to pass the test. And I think it's one of the things that the Evidence-Based Practice Institute has contributed is to come up with some way of measuring in some way the fidelity of providers delivering Triple P under contracts with the state, because we realize that just being competent doesn't mean you're really doing it the way you're supposed to be doing it. So, stepping back a little bit, of course, you can't really get to competence without people getting the specialized training and learning how to do it in the first place. And we do have sort of more support and evidence for the fact that, you know, when I like the title of this talk, more practice, less preach, that we all are on board with the fact that people, these are skills, and skills are not usually learned by having somebody tell you about them. They're learned by practicing them and getting better at them. And we use this always in our training, that doesn't matter what the skill is. Our skills are no different than the skills that an athlete develops or a teacher develops or something like that. And of course, we've just all been watching an illustration of, and what is the message from the Olympics? What have all those kids been doing? Practice, 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 practice. No one becomes a world-class elite athlete without doing nothing but practicing. So the essence, that isn't because somebody chatted with them about what you do on the half pipe. So on the other hand, the question of, do you need to have this, how much does the training itself, the classroom-based training, how important really is that? I'm kind of depressed about the last result I saw on this, because we spent so much time in our evidence-based training trying to really sharpen up our training to be lots more practice and a lot less, you know, preaching. But the Renaud, you guys, the study about the different types of training and consultation, where they had 3 different versions of learning the basics. A regular old training, a more of our kind with lots of role play and practice, and then online. And then they looked at consultation calls, because all of the training now goes beyond just the classroom training. But which they found, this is why I was depressed about it, that it didn't really matter which training you had. What mattered was how many consultation calls you were on. And what I take from that is that consultation calls are all about helping people do it with their real world clients, that the class is less important. It's more maybe like an infomercial, and we don't want to maybe invest so much in all these classes as we do in really working with people while they're trying to do it with their real clients. And it's a very interesting thing that I'm involved with some of my colleagues, the developers of TFCBT. We've been trying to talk about, well, what is good consultation? What should it be like? How can we do a really good job of helping people who now have this moment in time, maybe 6 months, maybe a year, depending on the intervention, where they have access to an expert who can help them learn to do it in real life. Now then there's the other part about, well, what are the actual competencies? And I know that everybody's on the Competencies bus, but I'm a little bit worried about competencies because there's no end to them. I mean, it turns out, once you get into starting to talk about competencies, the list gets extremely long of all the things that are required as competencies. And I'm worrying that when you have a list that is so long that people can't even remember what's on the list, what are the chances that people can really focus on learning all those competencies and then be helped to make sure they're doing all of them? Now, and I think this is actually a pretty good version of competencies, but as you can see, it's one theoretical framework and it came from one intervention, which is for anxiety. So how many should we have? And we were just, and of course, nobody really knows the full answer to that. So we were trying to think about that for this class we just did. And we were, in terms of evaluating it, we were going to ask people to self-rate their competence in what we decided were the key competencies, and then their supervisors are going to rate them, and we'll redo that and see how much agreement there is, and we're going to really be hoping that they're getting better, getting more competent. But trying to keep the competencies to a reasonable amount and to extract the ones that really would make a difference. I can tell you some of the things we left off and decided we don't care about those because we don't think they're that important, which is, and these are CBT interventions, so they have the CBT type components. But basically, psycho-ed, giving people information, coping skills, all that blowing bubbles and relaxation exercises, we didn't even ask them. Because we're not really convinced that people don't know how to do that, or that these are the things that people really need to learn. What we are asking people about is things like doing exposure therapy, because that's actually a kind of a difficult skill. Or restructuring a thought that somebody's stuck on, a thought that did not change when you said, "Oh, it's not your fault." So that's a skill, and it's not that easy. But it really made us think about who does decide which, and are we going to have a laundry list of every single thing people do when they're doing an intervention, or are we going to come up to some? Are we going to do some research to figure out which of the skills that actually really matter, and everything around the edges is kind of not so important? And should we be orienting our competence focus towards high value target competencies that are particularly difficult for people to do or stick with for a variety of reasons? So how do we know they can do it? Now, Doug, don't go getting on my case here. I didn't know you were going to be here, and I don't want to bring up the dreaded Gates Foundation in front of an educational person. But if, from my outside read of it, I know there are a lot of complicated things, but one of the things I thought was really interesting and important about this is the efforts to figure out how can you tell if somebody's a good teacher. And I think that, personally, I think that's actually much more important than what we do, because everyone goes to education and so much rides on it. So what I was struck by the fact that on this report, in which they talked about ways to empower teachers and to evaluate them, what is it you see them saying? They're talking quite a bit. They're literally saying that 30 to 40% of the overall score should be based on observation. So direct observation, a direct method of evaluating the teacher's competence. And how are they doing? Including videotaped classroom observation. And I thought that made a lot of sense to me from what just listening around the edges to the educational hoo-ha, that teachers aren't, if you don't have somebody who knows what they're doing, watching you do the job and giving you constructive, helpful feedback, it shouldn't be very surprising that some teachers flail around and have difficulty sort of being effective in teaching. And there are some people who don't really need that, but we're not worried about those people. So now I'm going to bring up the dreaded medical model as well, just trying to irritate people. But frankly, I would say the doctors and the training for medical professionals has a lot on what we do. Because doctors do not do what they do in private or in secret. It's, everybody knows the see one, do one, teach one. But medical training is very out in the open, and there are lots of people around when people are doing what they're doing in many, many aspects of medicine. People are seeing the skill modeled. They're not hearing it described. They're watching a doctor do the medical procedure, whatever it is. They have other people monitoring them. The surgeon is not in there cutting parts of your body out all by themselves. They've got a whole cast of characters who know stuff and can evaluate. And I thought this was a friend of mine, and on this very topic, because we're always thinking and talking about it, sent around to us this article about bariatric surgery. So it turns out that competence counts when you're a surgeon, too. So essentially they did a study and they rated the competence. They had experts rate the competence using, by the way, videotaped monitoring of people doing bariatric surgery. And it turns out that the more competent, I know this is a really surprising result, but the more competent people, basically there's a lot of better things connected to that. They do the operations in a shorter period of time. There tend to be fewer complications. People recover better. So they came out and recommended that this business of using a direct observation method of evaluating competence would be a good thing to add to the mix. So it's a much more systematic way of getting at directly observing and rating and giving feedback about competence. So we ended up basically really being persuaded that there really isn't a substitute for direct observation when it comes to competence. That hearing somebody describe how competent they believe they are really doesn't tell you what you need to know about whether people are competent at doing have the skills that go with the intervention. And some of our colleagues who disseminate PCIT out of UC Davis in California, they're doing more and more of their initial training to competence remotely literally they just give people iPads and a Bluetooth, and then they will sit in their offices and watch people do it and coach them. So they give them live feedback while they're learning, which I think if we thought about that, what could be really better than having somebody coach you in the moment, in the difficult circumstance, and guide you towards a successful, skill demonstration. And it's really, Anthony Urquiza, who operates the program down there, he just said it turns out this didn't require some big, elaborate setup or anything like that, because back in the day, all these PCIT rooms with remotes and cameras and this, that, and the other thing, which of course, really that, I can tell you, we have PCIT rooms and we're constantly having issues and problems with the technology. Something didn't go on, or something broke down, or this. And here you have really kind of everyday technology being absorbed into a method of keeping people competent, helping them become competent. So I stole this slide from Mark Chaffin. I couldn't possibly make a slide like this, and I doubt that he did either. But Mark Chaffin is at the Health Sciences, the University of Oklahoma, and we were part of a study that was a multi-site study in Washington State and Oklahoma, where community organizations were implementing PCIT learning and beginning to do PCIT, and we were comparing two methods of training people to competence, and one involved the standard thing that we all do, which is, and this is also kind of depressing, but you have to do a study. If we knew the answer, it would be no point doing the study, where the comparison was talking to an expert about your cases after you had done whatever you did, your sessions, or getting real-time live coaching. So in effect, we tested the proposition that Anthony Urquiza has now gone to as their method of training, of getting people to achieve competence. So they had, so PCIT, of course, lends itself very well to this methodology because PCIT itself is delivered remotely. So the provider is outside the room, coaching and reinforcing the parent in interacting with their kid in the desired way. And so that, and essentially all we did was add on somebody else behind the provider. So you have the provider coaching the parent, and then you have an expert coaching the provider. And most of the expert coaching was done out of Oklahoma. So there was no direct relation. And that's what this slide is representing. So we have the paper on this. We're at Revise and Resubmit, and it basically, what do you think the result was? Guess what? Coaching people in real time actually works better, and in fact, the telephone consultation didn't really work well at all in this case. And so that's what I mean by depressing, because once you have a result out in the peer review literature, it's going to be hard to say la la la. So how are we going to really pull that into how we think about getting people to be competent? How could you do that with interventions that aren't delivered in this way? I'm not sure how I see you can do that in Josh MST, where all your people are out in the field doing whatever they're doing. You know, and now it's going to be RoboCop. You know, they're all going to have little cameras on their heads, and you're going to be in your office, and you're going to be live streaming to them. So we might have to have technology get us a little more help on this. But I don't think this should really surprise us, that the best way to learn a skill is to have somebody help you do it in the moment, just like your coaches do for athletes. Well, I guess my PowerPoint is over. Oh, there we go. So we did ask our providers as part of our CBT Plus, it's from 35 different organizations, how do they determine whether or not their new people are competent? But it's really mostly this discussing notes and reviewing charts. Now they did say they did a lot of reviewing of audio and video tapes, but we were kind of surprised about that because we weren't really sure that that was totally accurate, because it didn't seem to strike us as that's every new person who's hired at a random mental health center is getting video and audio tape. And it turned out mostly interns are who they do the taping with, and probably that's because I think people have a little bit different outlook about training an intern and a sense of an obligation to really give them extra, help in getting them on board with the skills. But even sitting in on our observing sessions, only a quarter of the time that's something people routinely do with new people to their organization. So you kind of wonder, well, how would you know someone can really do this if you've never really seen them do it? I think that, I don't know how I would know about it. Not that I would want somebody sitting in and watching me or anything. So moving from competence, where, onto the, are they doing it, are they following the program good enough, basically, to give us confidence that the results are likely to be anywhere near the results that you see in the research studies. So one possibility for ongoing fidelity is ongoing direct observation. So an example of that we have here in Washington State is the Safe Care program. That is the only existing evidence-based intervention. It's designed specifically for families who have neglected young children. And it's a home-based intervention where it has 3 components: household safety, health safety, and basic parenting skills. But it's a very, very highly structured intervention. I mean, literally on the household safety component of it, the home visitor has a clipboard. It doesn't sound like a very good image, but apparently they can do it in a nice way. They literally go room to room to room in the house and identify potential risks and dangers, like under the sink. Do you have lye sitting under the sink? What if what about opening closet doors, et cetera, and so it's pretty important that when a highly structured intervention like that, you really have to make sure that people are actually following the program and doing the things that are in the intervention. So they require, as part of the ongoing monitoring, that once a month, visitors have a videotaped or directly observed, basically directly observed one way or another. Either they are watching them remotely with a camera or iPad, they're using the iPads as well, or they're going there with them. So that's an ongoing method of making sure people are following the program that is a required element of meeting their criteria. Now, I was very heartened. That is not, to my knowledge, nor routine practice in any public mental health setting. that the idea that you're actually watching what people are doing on that kind of a routine, regular basis. Now, I was surprised pleasantly to find out about an organization in our community that is doing that, which was very welcome piece of information, because what it shows is it's possible if somebody decides that's an element they want to incorporate into their organization. So is the Center for Human Services, and in their substance abuse program for kids, and they picked the senior leader that I talked to said they're doing this about once a month. They're actually going with people, or sitting in on their sessions, or having them tape a session. So that was kind of interesting for me to see, because I don't think that's routine in most places. But by and large, the methods for fidelity monitoring or adherence monitoring are basically indirect. Now, it always makes me kind of nervous to be talking about an intervention when the actual experts are sitting in the audience. So Josh, if I go off the reservation here, call me out on it. But my understanding of the way that a number of interventions like MST, like functional family therapy, or multidimensional treatment foster care, the way they make sure people are sticking with the program is that they have teams who do only that, and they have relatively modest caseloads, and that there is a very detailed knowledge and supervision of pretty much everything people are doing, as opposed to the normal. Now let's contrast that with the typical provider in public mental health with the 40 to 80 cases, maybe has an hour of supervision a week, and they pick and choose which cases they're going to talk about, and nothing is really basically talked about in detail. So, this kind of very intensive detailed case discussion is really a good method of getting a handle on what people are doing. And these are all interventions that have very good outcomes connected with them, and they all deal with very serious high-end scenarios. So it's not a casual, it really matters in terms of making sure that the program is stuck to, because if it isn't, it's probably not going to work. And there are a lot of, with high, these kids, the consequences of failure are pretty significant, not just for the kids, but for all of us. This is the typical if you have it type of way that people use as an indirect method of basically fidelity monitoring or adherence monitoring. Basically, it's a checklist. In this case, it's TFCBT. And this is an intervention I know a lot about and have a lot of involvement in. They use an acronym for each of the components. It's called practice. And essentially the checklist is just the components. And this is from a group that are funded through the National Child Traumatic Stress Network, and in order to get into the learning collaborative that they have in Wisconsin, it's out of the University of Wisconsin, people have to do this extra thing. They have to fill out a checklist and say how much time they spent in each session on each component. And then they produce graphs that have feedback for the providers. Now you can see right away some of the problems. One of them is this is one intervention for one problem that probably affects 10 to 15% of kids in public mental health settings. So if we have to have something for depression, we have to have one for anxiety, we have to have one for behavior problems, we have to have one for high conflict families, you have to have one for infant mental health. Now it starts to get super messy when you're thinking about you have come up with a checklist that's mapped on, and then I'm not even talking about, let's say you happen to have in your organization 3 or 4 different parent management training interventions. You have PCIT, maybe you have Triple P, maybe you have helping the non-compliant child. And my guess is each one of those operations has their own checklist for their intervention. So you could potentially, for one target, so behavior problems in kids, have 4 or 5 different interventions that are being delivered and 4 or 5 different self-report checklists. And so things very quickly get messy when you tie a self-report checklist to a particular version of a particular intervention, unless it's the only one you have. And of course, then there is the obvious weakness of the method, which is people telling you what they did. Now, how much weight can we put on that? There's some pretty good evidence that people's own reports about what they did are not entirely exactly accurate. But that's not meant as a criticism, because that's true of anything and everybody. That's just human nature. People aren't that great at giving accurate, comprehensive evaluations of something that they did or a certain situation they were in. But so it's somewhat weaker, and it creates now the complication of, well, what about the multiple interventions that a mental health center has to have on their menu to respond with an evidence-based approach to their clientele. Now, another indirect method that I think has sort of some additional value beyond just a self-report checklist is making your routine chart, note, documentation somehow prompt for and require documentation of what people actually did, and in some way tying that to the various evidence-based interventions. Now, everybody has to have a chart note and a progress note. That is routine practice. It has to be done. And so are there ways that people could construct chart notes or progress notes that were not unique to individual interventions, because we don't really want to have a situation where you have a different chart note or progress note for every single possible intervention. Our heads would blow off. But can we identify the key common elements that we want to know something about? So this would be for the benefit of a supervisor. Now, the other advantage to it, and I can tell you, this is our chart note. So we're not just using a chart note like this to get documentation for QA. We also use it to sort of prompt the providers to stick with the program. So the very first thing you might see on there is compliance with homework. Well, you know, it's kind of hard to fill that in if you haven't given any. And I have to say, not that I don't know if anyone has ever looked at a single progress note I have written, but I'm so paranoid about somebody looking and then calling me out for having an empty square where it says, well, you know, compliance with homework. So, and right down at the end, one of the last things is, what was the homework? So we adopt the idea, we're CBT basically, and we sort of adopt the basic principles of what a CBT type of intervention should include in terms of the structure of how it's delivered. And that involves having people learn skills and practice them in real life, which is why we raised up homework to such a high level. So it's not just providing documentation, but it's also orienting the providers towards sticking with the program. And there are a lot of things one could put in a progress note that could potentially be informative. And frankly, if we could nail that thing down, I think we would be in an incredibly valuable position, because everyone has to do that. But we have a really bad situation right now, and I know I was talking to Aaron earlier about the dilemma that we are, of the position we're in at the moment, which is we haven't really come up with a method to get to give people a place to do documentation where you can get the data back out. So we have it here at the UW Medicine, and we're very fond of telling people what they ought to do, but we don't always have a method to do it ourselves, because I've tried to get data out of workout, and essentially the message is that we can't do that. So putting it in and having no method to have it come back out, I think it's going to really thwart us. And all my colleagues out there in public mental health, they're all going to the electronic medical record, but they're buying it off the shelf. So you've got Sigma, you've got Avatar, you've got PsychNote, and each of those comes, with more or less flexibility, more or less modification. What kind of, adjustments can be made? How can people orient them to put other things in it? Because we're very interested in, one of the things I'm really interested in, because I think it's might be a better way to go, is scores on standardized measures. Well, if you can't really get it back out, it's not going to be very helpful for me to type right in. They had which I did, they had a 13 on PHQ-9 this week. But I'm not sure that's going to get us where we want to be if I'm the only one who knows that, and there's no method for it to be monitored. Now, I've had a lovely conversation with Maria and Rodavita about, okay, well, what about this team operation that she is an expert in and has developed a fidelity monitoring method? And I just thought this was a very useful framework, heuristic, and I think is probably what is used in many of these interventions that involve teams. So it's less what an individual is doing, but it's how does the team function and operate, and the model that she described to me, and again, this I might be missing, I'm sure I'm missing a lot of detail on it, but the gist of it is a site visit once a year, where there's direct observation of meetings, because they are supposed to be run and done in a certain kind of a way. There's review of the charts to see if there's documentation that the right things are in the chart, that things are supposed to be done as part of the ACT, the Assertive Community Treatment approach. There are surveys of both patients and staff to find out what they have to say about what they're doing. And then people are observed in the field. Now that's a pretty good triangulation method, if you ask me, of having multiple direct and indirect methods of getting at the elements of this very intensive treatment for serious mentally ill. And it seems like this model could, seems like it would be broadly applicable to these team-based types of interventions, like DBT, for example, where it's not just what the individual provider does in the room with the patient, it is how does the team function and operate, what about, you've got the skills group and the individual. So, and a couple days a year, if that's the program you're doing and that's what all the people are doing, that doesn't seem too outlandish as a method of people checking to make sure that the program is sticking with the program. And it doesn't seem like that should be a requirement that would be beyond the ability of an organization to do. Now for something completely different. Why is there so much emphasis on fidelity? Well, really, the reason we care about fidelity is because if you do it the right way, you get the outcomes. We don't inherently care that people are doing all these different programs in exactly the right way. We care because we have evidence that if you do them the right way, you're going to get better outcomes. It's the outcomes that we care about. And we really don't know at this point, to be honest, and I'm going to go back to the competencies point, we don't know which of the elements in each of these little packages is really that important. So it's possible that some of the focus on fidelity monitoring is sort of unnecessary, because maybe it doesn't really matter on if they do this, that, or the other thing, but what really matters is, do they do that? So investing huge amounts of energy and time, make sure they're following every detail, might not really be the best investment. But the most important thing we should be caring about, we should never ever lose sight about, our job is to help people get better. It is to help people with the problems they came to us for. It is not to deliver an evidence-based intervention. And I really was pleased to hear Bruce Torpeda speaking out very strongly about reminding us of the business we're in and why we're in it, and not getting too far afield from that. So of course, what that would say is, well, don't worry so much about fidelity, just worry about outcomes. And the evidence is pretty darn strong for that. I think this is a paper by Len Bickman where they didn't do anything. There was no evidence-based intervention involved at all. It was people just doing whatever they do, but they measured something. And I think they were measuring every session. I think it was just this relatively short checklist, and then somebody was giving, then they were giving feedback to the provider about how much, what people's scores were on this very, straightforward, easy measure. And guess what? People got better. So you didn't even have to change the intervention, which I thought was really, look at the whole enterprise we're in and teaching and coming up with all these interventions. What really mattered was that if a provider has feedback on a regular basis that people are or are not getting better, that really tends to get them to focus on doing something in a better and different way. Nobody's in the business of not helping people every day when they are a mental health professional. So I thought that was Now, they also had another finding, and I think this is really important, was that if the sooner the feedback comes, the more difference it makes. So waiting 2 or 3 weeks to give people feedback about something that happened 2 or 3 weeks ago is not as helpful, and people don't pay as much attention to it. Now, other approaches combine the provider's self-reporting on what they do and measuring outcomes. So Hawaii has the most elaborate system, as far as I know, in the country that involves documenting what providers in public mental health do and then having routine assessment. Now, Georgiana Sedlar and I from the Evidence-Based Practice Institute had a very interesting and useful conversation with the guy who oversees the data part of Hawaii, and he was really neat about identifying and acknowledging some of the weaknesses they still have. But it's kind of like they're on the right track. So, but mainly what it was, they gotta have another one of these suits. Lawsuits are good because they force people to pay attention to a problem and invest resources. So they were able to get the Hawaii Mental Health Department to invest in a data system. And as sad and sorry as this might be, I'm at the point of thinking that is our biggest obstacle right now. We don't have a good method for getting data in and then giving it back to people in a real-time way so that can impact their practice. Now, the thing about the Hawaii, which I want to call out because I think it's so admirable, it's that there's some funky things about it, and the lawsuit always leads to funky things, and for some reason that was not clear to me, that the regular old outpatient therapy is done under the education department, so really their mental health is dealing with the more high-end kids. But they did not adopt let's have a whole bunch of different interventions. They do have some packaged company-controlled interventions for certain populations, like they have MST. And I think a very strong argument can be made that certain types of problems and require and are worth the investment to have a highly controlled system of monitoring them that is run by the developers. But that's not feasible for the routine problem. Most kids who have mental health problems do not have serious ones. They have mild and moderate ones. So we don't want to orient our whole entire thing around trying to meet a standard that's designed for very high end. So what they've done is have a system that's broad. So it's not just one intervention for one problem. They went the Bruce Torpedo way, and this is the modular component. So literally to get reimbursed, the providers every month have to go in and type in for every client what they did. Now there's a lot more to it than this. This is just one page. They have to say what the target problem was, and then they have to say what they did. And then there's a measurement part of it. And here's an example from PracticeWise. This is Bruce Torpedo's company that offers this to anybody who wants to a subscription, where you go in and you say what you did and you measure something, and you can get a dashboard showing what you did and the outcomes. Now the big problem that was very interesting for Georgiana and I learned was they can't get the outcomes back to the providers. So it's going in, but it's not coming out. And I think that's a big downfall, and it's a big worry I have right now about our state that had a lawsuit, and part of the lawsuit is an agreement that for kids in the class, there will be a CANS done on them, which is, a communication device, but it's a systematic way of identifying what people believe are the problem areas, and leaving aside any question about the CANS itself. What I'm concerned about, because what I've learned from around the country is essentially it's a one-way street. So providers have to enter the data or report on these measures, but it never goes back to the providers. So it's really mainly used to put on a PowerPoint for the government to tell the legislature. Well, that is not going to improve practice at all. And I'm very concerned about how little attention is being paid to how we get this back. And even in Hawaii, they're prohibited from giving it back at the individual level. So what you really want is to get it at the individual provider level as well as the organization level. How are your people doing? Now, our very own group health has basically gone to this method of measuring outcomes at every session. I heard about it at the Seattle Implementation Research Collaborative conference last spring, and I just was so enthusiastic about it. The psychologist who oversees the outpatient clinic at Seattle Children's Hospital, she and I were both like desperately like, well, how did you do that? And how can you make it happen? Because they've gone a very similar direction, which is you measure something at every encounter. So Group Health now does this for all their behavioral health clinics all over the state, tens of thousands of encounters. The patient arrives for their appointment, and this is only right now implemented for 12 and up or 13 and up. Every patient who checks in for an appointment gets a one-page thing that has, this is what it is. I mean, this is what it's the PHQ-9, the GAD-2, and the audit. So they're assessing at every session level of depression, level of anxiety, level of substance abuse, as reported by the patient. The downfall of it right now is that the patient takes that piece of paper and gives it to their provider, and then the provider has to enter it in and have it scored in their patient record. Now they actually have an integrated methodology, which is and it's in Epic. So that's kind of neat, and I thought this was a really neat way to go, and I thought it was so neat that we're going to do it in our clinic as well, and we're going to be starting that in another month or so. We're going to have people fill it out on tablets, and to see if having real-time feedback about how people are doing that. We already do that, a lot of us ad hoc or clinically or on a piece of paper, but having it graphically represented, I think will actually be more interesting and meaningful to patients. Now here's some other evidence that our very own Jürgen Unitzer, the new chair of the psychiatry department, in the work he's doing on collaborative care. Basically, they published a paper last year that was really interesting because essentially it just goes to show the basic principle of incentives. People do what is reinforced. So as a way to make sure people stuck with the program, meaning did the things that the care manager is supposed to do, and it's pretty flexible, and measured, they used the PHQ-9, measured depression at every encounter. They basically withheld the 25% of the reimbursement rate as an incentive to get people to follow the program, so to maintain adherence. See the people within a certain period of time, get the PHQ-9, and the way their methodology is, if the people haven't gotten better after 4 administrations, then you have to get a consultation, because they're not operating on if they haven't gotten better, let's do more of the thing that isn't working. They are operating on let's stop and talk about it and figure out why it isn't working and should we be doing something else. And guess what? Fidelity and outcomes improved significantly with this creation of incentives. So I just want to talk for a second about a study that our very own Shannon Dorsey is doing to try to tackle these complicated questions within a public mental health context, where she's trying to figure out some things that supervisors in real life could actually do without having to do something that's above and beyond what they're already, adding on a whole extra thing, and seeing if you can improve outcomes and fidelity to an intervention. So she has 2 conditions. One, the providers are entering an outcome measure at every session and saying what they did. And one condition is the supervisor talks to them about it and discusses it in detail. And the other is adding on, in addition to symptom and fidelity monitoring, having people practice a skill that they're going to use in the next session. So we're right in the middle of it, but I think this is going to be a very interesting study, and it's a very interesting example of a creative way to try to help us figure this out. And we have behavioral rehearsal guidelines for every single skill that we think is important in the delivery of this one intervention. And we're using our toolkit that we've developed through CBT Plus as the method for entering the data. So this is what a supervisor and a provider would see, and they can evaluate why is something going up and down. Hopefully, they wouldn't be checking every box. That would be a bad thing, because we don't want people doing everything every time. So at the end of the day, I would say our thought is invest in initial competence. That's really, really worthwhile for organizations to do, and use direct methods for establishing initial competence. And we're calling it supervise the heck out of it. Your first training cases, the first cases people do when they learn an intervention. Because it seems to me that having success at delivering the interventions is one of the things that's going to create internal motivation on the part of the providers to do more of it. And we should help them be very successful the first time out and using direct methods. For everyday fidelity, it depends on what's possible in your context. You can use direct, you can use indirect, some combination. There are things you can easily incorporate, like detailed case discussions. You know what people do in supervision now? They spend most of their time talking about the past and almost none talking about the future. Well, the past is actually already over. So we need to reorient some of the supervision practices towards helping people do new things in a better way. Progress notes, that's easy. Anyone can do that. Or make a new progress note. We have a system in our clinic of 10%, a random selection of 10% of visits each week. The supervisor gets a list and they go and look at it. And if something looks funny or they haven't been interested, that case gets on the calendar for supervision. And outcome measurement. I think that's really the best place to put the buck. So my view on this whole thing is we do have good news, which is there are a lot of different options. There isn't just a gold standard way, and if you're not doing that, you're really doing a bad job, which is very important to get real people in the real world on board with this. If the message is you have to do it this way or else, people will go with the or else. Because some of the things that are required to do it at the gold standard, that means outside money or a special program for a special population. And so I'd like to, us to go forth with coming up with more options that are practical and can be incorporated, and as well helping people see what are the better methods in their setting and in their context. And that's all I have to say.
We have a few minutes for questions if anybody has any. And if not, we have certificates of completion available, but that will commence our lecture for today. Thank you, Lucy.